Dr. Nadia Lafferty, who is a pediatric advisor for MSF Barcelona. She has done field missions for MSF, and now she's stepping up and helping out in the field. She's taking over for Daniel Martinez in Barcelona. Please welcome her, Dr. Nadia Lafferty.
To you all today to give you a little bit of my experience with MSF. It took me a long time to decide how to focus this speech to make it interesting for people who had never worked with MSF before and for those of you with a vast amount of MSF experience. So what I'm going to do is just take you on a little bit of my journey with MSF to try to give some of you without any MSF experience more insight into what it means to be a paediatrician in the field, to try to inspire some of you to come, and for those of you within MSF to show you kind of where we've come with paediatrics over the past few years. So I'm going to focus on settings like these. Most of my field experience has been in very resource-poor settings, so in places like Western and Central Africa, where either we're working in very basic district hospitals, or in tented structures, sometimes in response to emergencies, like in refugee settings. And this is where we have the most clinical challenges in the field, and so I want to highlight that a little bit. So I joined MSF in 2012, and I went on my first mission as field paediatrician to the Central African Republic. And for me, this was a very steep learning curve. I had come from a background of paediatrics in a Western setting. I did my medical and paediatric training in Glasgow in Scotland. And what I remember when I first came to my setting in the Central African Republic was on my first day we did a tour of the hospital and people started talking about intensive care. And it's interesting that we had a little bit of this yesterday as well. And I thought, oh wow, we're actually in a much more developed setting than I had appreciated. So we did a tour of the hospital, and we stopped in this small ward with 6 beds, a couple of oxygen concentrators, and some IV fluids. And people started giving the handover of intensive care patients. And I kept thinking to myself, I wonder when we're going to go to intensive care. And it suddenly dawned on me that we were in intensive care. And as I looked around, I did see intensive care patients. For sure, these patients were in need of intensive care. But what I could see in front of me was not what I thought was an intensive care. And this was the start of my journey with MSF and my learning to adapt to the setting that I was in. Over the next few months, I found it very challenging. I felt as though my previous experience as a paediatrician didn't really help me at all. A lot of the diseases were new: malaria, malnutrition, measles. I didn't know how to manage these illnesses. I had studied them for sure, but I was no expert. I was used to dealing with laboratories and diagnostic tools to help me either confirm a diagnosis or to help me to hone my diagnosis. And I was dealing with hemoglobins and blood sugar levels. This is all I had in the field to help guide me. Even my history taking became a major mission. I had come from a school of thought where 80% of my diagnosis was based on history taking. But when your history is taken through a translator, or sometimes no translator at all, and it consists of diarrhea, vomiting, cough, and fever, I had not a lot to guide me. So I started to use more of my examination skills to help me, and also my observation skills, just to look around and see what was happening here. One of the other things that I experienced in my first mission was a feeling of isolation. I felt quite alone in the field. I had come as the first paediatrician in this mission, and people looked to me like an expert, and I felt nothing like an expert in this situation. And so I felt a great deal of responsibility, and I wasn't sure who to look to get support. And with this responsibility, of course, comes feelings of guilt. Surely I could have done something better. If a child died, I should have changed the antibiotics 2 or 3 days ago. I should have done something else. And I really felt in the first few weeks that they had sent the wrong person. And it took me quite a long time to appreciate the skills that I did have as a paediatrician and the things I could use in the field that were actually invaluable and that other people didn't have. I think we sometimes forget that people who don't have any background in paediatrics, nurses and doctors and other healthcare workers, are quite uncomfortable in dealing with children. And when it comes to neonates, they're completely terrified. And what they often do is avoid looking after them altogether, or they treat them the same as adults. And we all know that children are not just small adults. They're different. So it's for good reason that people are afraid of children, but what we need to try to do is make the general population, the general healthcare workers, not afraid of children. So the skills that I suddenly started to realize I had were things like examination of children. Pediatric examination is an art. It's not something that we can learn overnight. It's something that you develop over years and years and years, and you take it for granted at a certain point. But in fact, I saw very quickly in the field that people did not know how to examine children, and they couldn't get anything from the examination because they were approaching it in the wrong way. We know that there are pediatric-specific diseases like asthma, bronchiolitis, croup, congenital heart disease that I could manage because I had seen these things in my daily practice, but people in the field diagnosed almost all of them as pneumonia. So I could bring this level of a more clarity of diagnosis, more thought about the diagnosis, and not just assume that it was pneumonia. Our drug dosing, fluid management, resuscitation, they're all different in children compared to adults. So we can bring quite a lot to the field as paediatricians, even if you don't come from a tropical setting. So with this realization that I had some added value in the field, I became a little bit more confident and a little bit more innovative about what I could do. So in my second mission, we had a neonatal ward. So this was just a small room which we tried to keep warm for the babies. And I realized, having no incubators, that one of our major challenges was going to be hypothermia. And sure enough, when I looked at all the charts, most of the babies were very hypothermic overnight. And nobody had ever addressed this issue before. Nobody had really put this together with perhaps our high mortality rate. Why were these babies dying? Were they hypoglycemic? Were they having apneas? A lot of these things could be linked to hypothermia. So what we did, we set about trying to keep these babies warm. So we made a very warm room, which was a nightmare to work in, but was great for the babies. We got plastic boxes, and we put babies inside plastic boxes and cut the lid off to try to mimic an incubated environment. We implemented kangaroo mother care or skin-to-skin care, which we use more in the West, in a group session, because mothers are very resistant to kangaroo mother care, but to try to get them to do it together at a certain time in the morning when we knew the babies were the coldest, when the mothers were in bed anyway, then we asked them to do it together. So we tried to use it as a group session. I also looked to more the softer side of paediatrics. So how do I make my hospital environment more child-friendly? Because we know that this is quite neglected in developing settings. It's probably a bit of a luxury, but where I come from, we're very used to having play therapy and having places where we can give another side to paediatrics than just the medical care. So we did things like make signs for the wards. We brought toys to the children. And one of my proudest moments was getting my whole expat team, when I was medical team leader, to spend the weekend painting pictures to decorate the paediatric ward. And you've no idea how much of a difference this makes to children in the ward, in developing settings as well as developed settings. So I feel like paediatricians or people with paediatric experience in the field can be advocates for children as well, because they see things that other people might not necessarily see. But there came a point where I felt like my 6-month missions in the field wouldn't have so much impact on the wider paediatric movement within MSF. Everything I was doing was for this one field, and it wouldn't necessarily have any bearing on other missions. So I started to focus much more on teaching and training, trying to be involved with capacity building in the field. And I also started looking at other positions within MSF, because I realized that as a field paediatrician, it was very interesting and you have a lot of clinical input, but you have, as I said, a much lesser impact on other projects. So it brought me to this point where I started to look at all the different possible positions there were within MSF as somebody with paediatric experience. And you'll have heard talk about all of these positions over the past couple of days. There are mobile implementation officers, or MEOs, flying paediatricians, paediatric advisors, paediatric trainers or mentors. So for those of you who are not with MSF, I can understand it can be very confusing. For those of you in MSF, it's probably even more confusing, because each section has a slightly different definition of what each role stands for. But I decided to go as a paediatric MEO, a mobile implementation officer, with MSF Spain. And now this role for me, and let's say for OCPA, the MSF Spain, is much more of a strategic role. It's much more focused in the field. So it's a field position, which allows you to still have contact with the field and to have an impact on a specific field, but more for one specific tool. So rather than doing generalized clinical care, maybe you're going to implement the paediatric early warning system. You're dedicated to that one position. And there you can have much more impact for the longer term, and implement perhaps the same thing in several fields. So after a year of doing this job, which also gave me a lot more training and teaching experience, it kind of gradually moved me into the paediatric advisor role, which is where I am. I'm about to start. I haven't started yet. I'll start next month, again with MSF Spain as paediatric advisor. The paediatric advisor role for me is the most strategic role as someone with paediatric experience within MSF. It allows you to keep contact with the field because you go on field visits and you can have that direct contact with the field. But it's much bigger than that. It gives you a much more global picture of what's going on in all of your missions in paediatrics, not just one mission here or there. And it allows you to develop tools as well. It's essentially an office-based position. It's not a field-based position. So you have the time to develop tools such as guidelines and protocols, which can be implemented in several fields and adapted to the specific field setting, which I think in the longer term will have much more impact on our field activities. And you're also involved quite heavily in teaching and training. Another reason why I felt the paediatric advisor role was very important was because I wanted to give this support to people in the field that I felt I'd maybe lacked in my first mission. I don't want first mission paediatricians to go to the field, or any doctors for that matter, looking after children and feeling uncomfortable. And I think it's important that we develop that team spirit and that teamwork and have an approachable way that people don't feel embarrassed to ask questions and ask for support. And I wanted to be involved with that. I think there's a lot of debate about whether or not we should have paediatricians in the field, or if we can work with general doctors with some support from the office-based people like the paediatric advisors. And I think that there's not a blanket rule for that. I think in some situations we do need to have paediatricians in the field. We have some very large hospitals almost with subspecialties like neonates, which people don't necessarily... There are a lot of doctors who might have paediatric experience, but not subspecialty experience. And I think it's very important that we put paediatricians where we have large paediatric activities, especially subspecialties. But I think in other settings, we can use general doctors with paediatric experience. There's no reason why we can't. We do have a support team. We have meals. We have in other sections flying paediatricians who can go and give a bit of extra support. And I think a lot of this depends on the size of your activity, the level of care you want to put in place, the competencies of the national staff. And it's really a decision which, again, as paediatric advisor, you can be involved with, which is very interesting. So between the operational unit and the paediatric advisors, you can come to these kind of decisions together. But I think it's very important that we do keep paediatricians within MSF, because, or people with paediatric experience, I would say, because they will advocate for children and make sure that we don't forget the important things that children need that adults don't need. I'm just going to wrap up a little bit by saying that I'm really impressed by this initiative here, and I think it's imperative that it continues. Sometimes people within MSF, we can get a little bit focused on MSF, and we can start to sometimes accept things that other people wouldn't necessarily accept. Things are so basic in the field that you sometimes say, oh, this is just MSF, and you accept it. And I think this kind of forum allows us to push ourselves and to see the bigger picture and to keep us in the loop also with westernized medicine, which is very difficult when you're in one field rather than the other. And so this has allowed us to have opinions from experts, latest research, but also to all put our heads together and see how we can use this research to adapt it to our context. It's not one person who's able to do that, it's all of us together. And I think it's very important that we continue this initiative. And I am very excited to see what's going to happen over the next 5 to 10 years with paediatrics and MSF. I know it's going to change enormously, and I really look forward to being a part of that and to being back here or in a similar environment at the same time next year. So, thanks.
Thank you very much, Nadia. Very, very inspiring. Thank you. Do we have any questions from the audience or from you streaming? Perfect. Yes, there we have one. Honey.
Thank you very much for this talk. I'm not a pediatrician, but I guess I qualify in as an interest in pediatrics. As I've been in many MSF missions, pioneered some pediatric hospitals, and did a lot of work when it comes to training as well. And my question to you, are you working in a specific training module for our volunteers who are going to the field, who maybe have the skills and they just need a little bit of refining those skills or doing something else?
Yeah. So we've worked a lot in the past few years of training and teaching materials in paediatrics. So intersectionally, there will be guidelines that are coming out shortly in paediatrics and neonates, which will be used in the field, but also within OCPA, and it's something that we're going to try to share with the other sections. We're developing an online training package because we know that we can't always give a pre-departure preparation in depth in every single specialty. It's inevitable. But if people are going to work in paediatric missions, there are programs for neonates, sickle cell disease, diarrhea, pneumonia, these kind of things, online training modules that you can work through by yourselves to, like you said, refresh your memory. They're relatively basic, but they give you what you need, first of all, to understand the illnesses and also to know our protocols because we have our treatment in it as well. And that's something we're going to, I think it's going to be launched very soon. It's not quite active yet, but it will be there in the next couple of months.
Marie-Claude. Oh. Okay, you wanted to add, and then...
Hello. Add to what Nadia has just said, there's also a pediatric training and there is a neonatal training that is held in the field and in headquarters. The pediatric training was just recently developed. The neonatal training exists since a few years, which is pretty much the pediatric training, at least I can say, is simulation-based and modeled along the APLS training, which some of you might know, but adapted to the context in the field. And there was a poster on it yesterday outside for those of you who might have seen it.
Mm-hmm. Yeah, there's been the neonatal training for a number of years in this paediatric training, as Myrtle said, that's been rolled out into the field because often our trainings are done in headquarters and we're trying to move more towards giving trainings in the field, not only for expats but also for national staff, because it's quite difficult to bring all of our national staff to the headquarters and inevitably we reach a small population rather than going to the field where we can actually possibly teach half of the people in the same facility, which will have a much greater impact.
In fact, I wanted to say that Myrtle, my colleague, said, but just some precision. So he's a pediatric advisor, the 5 that are doing the pediatric working groups as a core one to coordinate between all sections. And it's all the pediatricians you have seen on the previous slide that are the extant pediatric working group. For the training, they are existing since 2009. But now they are intersectional one, and there is not only the training done in the capital, so Paris, Geneva, Amsterdam, or you can see, there is initiative in the field, in regional office, Kampala, Dakar, etc. And there is also training done directly in the field. Because the rationale now for us is not only to give the training, but after to support people in the field for the implementation, to stay with them 1 or 2 months, to really work with them. And that is the role of the training people, the pediatrician in charge of training, coaching, or mentoring. So they are staying in the field after the training to help people to make the change that were taught in the training. So that we would like the pediatrician is really to put the training available for everyone, but also not only in the capital, but in the field, and to be very close to the people and to help them to improve their daily work.
Thank you. I think maybe just a short one.
Last question, Frederick Sorge. How do you deal with local pediatricians? I mean, do you have special relationships with the national pediatric institutions?
For the most part, there aren't any. Where I've worked personally, I've never worked with a local paediatrician. There are other, I mean, sometimes we work without doctors. So a lot of the missions where we work, a lot of the places we work, there are very few doctors in the whole country. So we're working with clinical officers and medical assistants who have done about 3 years. It's like 3 years of a medical school training, but it's a specific qualification. And these are the people who are looking after patients. Sometimes we have nurses, but I would say most of our projects we're working with medical officers, clinical officers, this level. If we're lucky, we've got some national doctors, and I don't maybe in some countries there are some national paediatricians, but as I said, I don't have any experience of that. But there are some initiatives to make collaborations with universities in other countries, like in Senegal, where we can try to use the local facilities who are producing paediatricians and who have a training curriculum already to see if we can somehow integrate with that to produce paediatricians in these countries or people with some sort of paediatric experience. Because for sure, I think developing national capacity is how we're going to progress. There are a limit to the number of expatriates who go, and most people don't stay in MSF for a long time. Most people come for a couple of years and go back to normal life, normal training, the normal career path. So I think it's really important that we try to develop capacity in the countries that we're working in.
Thank you, Nadia.
Thanks.
Thank you very much.